Welcome. Atsushi Hachimori works at Tsunagaru Clinic in Yokohama. He will walk us through a hospital-at-home study from 2025. This is work PP-005 at APHaH 2026. Atsushi, may we begin with the setting? Where does this work take place and why is that place important?
Our clinic sits next to Nova Danchi. This is a public housing complex of about 6,000 homes, built in the 1970s. The local aging rate is over 50%. Many buildings have no elevators, so frail older residents are trapped on upper floors. Medical and social vulnerability meet here. That is the population our study covers.
Before this study, what was still unclear for home-based acute care?
3 gaps motivated us. First, severe frailty and dementia are usually left out of hospital-at-home trials. Second, real-world urban evidence beyond Western trials is thin. Third, it was unclear whether one community-based approach could carry patients from acute illness all the way to end of life. Our study addresses all 3.
How did patients move through the study from first visit to final review?
From 583 home visit patients in 2025, we identified 76 hospital-at-home patients with 88 episodes. We also identified 7 hospital admission comparators. The total analyzed was 83 patients.
What was the main result and how should we read the 91.6% figure?
Here's the headline. 76 of 83 patients completed acute care at home. That is 91.6%. The Wilson 95% confidence interval was 83.6 to 95.9%. And just as important, no hospital-at-home episode was interrupted by an unplanned hospital transfer after start. 0. This was in a frail population, with dementia and partial bedridden status, and with no remote monitoring tools.
Who were these patients in real life, beyond the diagnosis names?
Let us anchor what frail means here. Median age is 86. Dementia 80%. Documented do not resuscitate orders 88%. Bedridden 50%. These 4 numbers describe a population most international hospital-at-home programs would turn away at the door.
What kinds of acute illness were treated at home?
Infections 57%. Dehydration or disuse 23%. Together, these are 4/5 of all hospital-at-home cases. Intravenous antibiotics were used in 55% of episodes, mostly ceftriaxone. Ceftriaxone is once a day and well suited to home delivery, and 94% of patients received hospital-level treatment intensity.
How was the choice made who stayed home and who went to hospital?
This is the panel we most want you to look at. Why were these 76 at home and those 7 in hospital? Disease category differed strongly with P less than 0.001. The hospital cases were heart failure escalation, or needs for procedures such as coronary angiography or chest drainage. Male sex also differed, with P equal to 0.009. And the vast mass were men. But here is the surprise. Severity, P equal to 0.809. No real group difference. So in this exploratory comparison, disease category, more than physician-rated severity, appeared linked to the choice line. With only 7 hospital patients and no adjustment, we present this pattern as a clinical reading, not a causal claim.
What did the study show about care near the end of life?
Within the same home care setting, with the same clinicians and the same nurses, There was a parallel group of 111 terminal cancer patients in 2025. Documented do not resuscitate orders, 98%. Opioids used, 82%. And among the 100 who died, 56% died at home. The two groups are different patients by design, but the same care model carries both acute hospital at home and month-long end-of-life pairs.
When you step back from the numbers, what are the key findings?
4 key findings appear at the bottom of our work. We openly note the limits. This is a single-center retrospective study with a small comparator group and with no adjustment for confounders. Prospective multi-center studies are needed.
Thank you for listening to this work. For thoughts or to ask for the full work, please use the address shown at the end. Atsushi, any final thought?
Thank you. This work continues, and we hope it helps more people receive acute care in the place they know best.